Hi everyone, I'm Dr. Vidhya, working as a Pediatric Ophthalmologist at Sankara Eye Hospital, Bangalore. Today, as a part of a lecture series on the International Day for the Disabled People, I'm going to take you through the evaluation of a child with visual impairment. As we know, there are so many causes of visual impairment in children, starting from anophthalmos or microphthalmos to all the conditions like the cataract, chorioretinal coloboma, congenital glaucoma, CVI, retinoblastoma, ROP, PHPV, etc. Today, I'll be confining myself to the topic of CVI. So CVI, the cerebral visual impairment, this terminology encompasses both the cortical and the subcortical visual loss in children. It is the leading cause of visual impairment in children in developed nations, and it's slowly increasing its trend in developing nations too. It is identified by a normal eye examination or a condition that cannot explain the profound visual loss. When we ask the history, usually the parents come up saying the neurological problems as well. Usually these children have a unique visual and the behavioral characteristics. CVI can present in many ways. The unique characteristics in CVI are the color preferences, the need for movement, visual latency, visual field preferences, difficulties with the visual complexities, difficulty with the distance viewing, light gazing or the non-purposeful gaze, absent or atypical visual reflexes, visual novelty, and the visually guided movement. We will see one by one. So the history is the first step in the process of evaluation. The prenatal, natal, and the postnatal complications in the mother give us a clue for the incidence of CVI in the children. When we ask for the medical background, usually they come up saying the neurological problem the child is going through. And behavior at home also gives us a clue about the problems faced by the child. There is a questionnaire developed by Dr. Dattan, which has about 51 questions, which takes us through the 7 subsections of CVI, namely the visual field, search, complex scenes, guided reach, perception of movement, attention, navigation, and recognition. When the parents answer these questions, we will come to know exactly where the child is struggling with. The observation is very important. A single observation in a single environment will not give us the exact problem of the child, as these children have influences with the environment and with the different objects as well. So the child need to be observed during a quiet and a noisy environment, during the near and the distance activities, with the familiar and the novel objects, with the cluttered and the simple backgrounds, with the stationary and the moving objects. So the professional working with these children should do a specialized functional assessment, which focuses on the visual and the behavioral characteristics of CVI. This assessment will evaluate the degree of each characteristic of CVI in that child. It measures how well a child uses the vision to perform the routine task. Starting with the visual acuity. The visual acuity in CVI can range from not following light to a good visual acuity. But to remind all of you that visual acuity is only a small portion of the visual function. So in this video, you can see the child being tested for the fixing and following of the target. The child is able to follow the objects briskly. In this video, you can see the child being tested for the preferential looking with the LIA paddles. The child is comfortably seated in the mother's lap, and then we need to do the checkup. So preferential looking can be elicited using the LIA paddles or the cardiac acuity cots. In older children with a better visual acuity, we can use a LIA symbol chart or the Snellen's chart to elicit the visual acuity. In children where the visual acuity cannot be elicited, we can use the visually evoked potentials to elicit the visual response. In these children, we have to assess the viewing distance. In Many of the children, their distance vision will be obscured. In this child, you can see when the child is asked to see the cartoon played in the mobile, the child is coming close to the mobile to watch the cartoon. In this child, in this video, you can see the child is taking the target so close to look at the features of the target. So this will give us a clue about the working distance to be used by the professional working with these children. Coming to the color vision. Some children with the CVA have color preferences. Usually the parents are a better person to say about the favorite colors. If the child has a preference for the red color, then the professional should plan for the objects or toys with the red color, like the red color plate, red color spoon, fork. All these things will try to increase the visual attention of the child. Acquired damage to the temporal lobes can lead to abnormalities of the color perception with anomalies of how colors are seen and interpreted. Usually, we use the HRR pseudo-isochromatic plates to elicit the color vision in these children. Need for movement. Children with the CVA prefer to see a moving object when compared to the stationary objects. The same is the reason for the children getting more attracted to the objects with the shiny surfaces, shiny reflecting surfaces, because they give an illusion of a movement. The same reason being why they gaze on the ceiling fan, which is moving slowly. Visual novelty. It is very normal for the children to get attracted towards the novel objects or the targets. But some children with the CVA have an anti-novelty responses. Here you can see when a child is presented with a novel toy, the child ignore as though there is no stimuli presented in the visual field. But the same child, when presented with the familiar toy, you can see with how much force the child is pulling out of the toy. So this anti-novelty responses are noted in some children with the CVI. Visual latency. It represents a delay in response to the visual stimuli. Here you can see, though the stimuli is presented in the visual field, the child takes little time to look at the target. So this time to be noted by the professional. This would give us a clue about the utilization of the functional vision by the child. In resolving CVI, the visual latency decreases. Visual complexity. It is a difficulty in processing simultaneously presented multiple competitive stimuli. You can see this child, the child is very brisk in pointing out the target when I asked him to show the horse here. When a CVI child is shown, you can see the child is taking the chart close to the face to declutter the target so that he can locate on the target. The children with the CVI will be better viewing a single target when compared to a target with a complex background like this chart. The bilateral posterior parietal damage can lead to the dorsal stream dysfunction, which will make them unable to see multiple targets simultaneously, which is also called a simultagnosia. They will have a difficulty in locating a specific toy in a toy box or an item of clothing in a pile of cloths. Light gazing and non-purposeful gaze is shown by some children with the CVI. You can see the child is gazing without any target presented over there. These atypical visual reflexes may be manifested by few children with the CVI. One is the visual threat response. When a child is shown suddenly an object in front of the face, the child will blink the eyes. The visual blink response. when we tap at the bridge of the nose, the child tends to blink the eyes. You can see in this video. These visual reflexes are absent or delayed in children with CVI. Impaired visually guided movement. Whenever a child is shown a target, in this child, you can see when the target is shown, the child will locate and keep moving towards the target while the face is turned away from the target. You can see again here, the eyes look away from the target when the hands go towards the target. This is classically seen in children with the CVI. This can be involving the upper limb or the lower limb. The outstretched hand may be brought down onto the object, or the hand may reach out beyond the object to hold the object. There can be an inability to distinguish a floor boundary from the step. There can be problems with an uneven surfaces. Visual fields are usually elicited with the Lia flicker ones or with the arc perimeter. In this picture, you can see the examiner is trying to elicit the visual field using a Lia wand. First, it has to be elicited binocularly, then uniocularly. You can see the child focusing on the light, able to recognize the light and move the eyes accordingly. The unilateral damage to the retrochiasmal visual pathways can lead to a complete or incomplete homonymous hemianopia. Bilateral damage to the posterior visual pathways can lead to a lower visual field loss. This need to be taken into account. It's mainly for working with these children where we have to provide the visual stimuli to make them to get their visual attention. The contrast sensitivity is significantly reduced in children with the CVI. This can be elicited using the Hiding-Hedy charts or the Pelly-Robson chart. Here you can see the examiner trying to elicit the contrast sensitivity using the Hiding-Hedy chart. Impaired eye movements. We have to check for the pursuits, saccades, the unstable fixation, which is more common in CVI. The fixation need to be tested whether it is central, steady and maintained or not. Then tracking and the scanning to be checked. For checking the tracking, we need to ask the child to follow an object within 1 meter distance. It can be an illuminated or non-illuminated toy. If the child is not able to do so, we have to reduce down the distance and look at 50 centimeter. The scanning, we have to check the scanning by using 2 targets placed within 1 meter distance, whether illuminated or non-illuminated toy, and then check for the gaze fixation. Then the strabismus and nystagmus need to be evaluated in these children. You can see here the examiner trying to check the pursuit. You can see the child following the targets. Now you can see the examiner showing 2 targets and the child is asked to shift the gaze from one target to other, checking for the saccades here. So you can see how the child is following the target. So we can use an illuminated or a non-illuminated target according to the visual needs of the child. The other impairments which are common in children with the CVA are the impaired attention, causing the difficulty in performing more than one visual task at a time. Impaired recognition of people, impaired recognition of faces despite the adequate vision, which is called as prosopagnosia, impairment of recognition of the objects, shapes, and letters, profound difficulty in route finding, which is called as topographic agnosia. Each and everything to be evaluated in detail to get the exact picture of the child before we go ahead with the treatment strategies. Refraction. Hypoaccommodation is common in children in about 50% of the children with the CVI. Usually they are young children and they are more hyperopic. The additional magnification from the hyperopic lenses may also compensate for reduced acuity and the visual crowding. Dynamic retinoscopy is must in these children. Here you can see the child is not able to fix and follow the toy. But once the hyperopic glasses are given, you can see the child responding to the visual stimuli. Coming to the ocular comorbidities. So once these evaluation is done, then we have to check for the anterior and the posterior segment examination. We need to evaluate them to look for other ocular comorbidities in these children in the form of a high myopia, ROP, glaucoma, retinal or optic nerve diseases, which also can alter all these characteristics which we have seen in the CVI. The structural and the functional neuroimaging approaches can help gain insight into the abnormalities of the white matter connectivity and the cortical activation patterns. So it need to be done in children with the CVI. So what is the need for assessment? It is very important because there is still a window of opportunity during the infancy and the early childhood. When a child's visual system is developing rapidly, the central nervous system can be receptive to influences of intervention. So these need to be diagnosed early and the intervention started early. Second thing is, according to the evaluation findings, we can tailor the treatment strategies in these children. Now, what is the checklist for evaluation? So after going through all this evaluation process, now we should have a checklist, what all the things we should assess in these children. As we all know, the functional vision assessment, which includes the visual acuity, color vision, visual fields, contrast, pursuits in the saccades, tracking and scanning, and the fixation pattern. Coming to the specialized evaluation, which has the need for the movement, that is the visual attention, visual latency, difficulties with visual complexity, light gazing and the non-purposeful gaze, absent or atypical visual reflexes, visual novelty, and visually guided reach. So all these need to be checked and the degree of involvement need to be assessed in these children before we start with the treatment strategies. So I conclude by stating that an understanding of CVI is essential for all those involved in the everyday life of the child. The problems must be identified and the solutions sorted out. The full range of visual limitations is identified, characterized, and worked within while deriving the tailored educational needs of the child. We can bring about a lot of change in these children if we start with the evaluation properly. These are my references. I thank Dr. Kaushik Murli for giving me this opportunity. And I thank Ms. Anita and Ms. Bhavya of Sankara Eye Hospital, Bangalore for helping me with the video preparations. Thank you.